guys so much for having us, and thanks for being here. Thanks for that awesome introduction. Maybe to get to know each other a little better, we thought we'd tell you a little bit about ourselves, but we decided we would each tell you an interesting fact about the other, so I'm a little afraid what she's going to say after. So with that, I'll start. And a little known fact about Amber is that she's my barber. For those listening on recording, she doesn't have a very hard job, just a little on the side, basically. We were blessed to meet at a Catholic medical conference a few years back, struck up a wonderful friendship, and then just God saw fit to have a lot of beautiful things fall into place in order for us to get married and start our lives together a few years ago. So she's also one of those people that is insanely happy and perky in the morning, and I'm the opposite of that. So that's been an interesting, fun learning for both of us, and we've come up with a good middle ground, I think, right?
Yeah. On the flip side, I shut down at about 8 p.m. and Paul could be up until midnight every night with no problem. So unfortunately, there are a lot of nights on the couch when Paul's reading a book or watching a movie or something, and I'm just passed out on it. Where it's kind of a win or lose-lose, I don't know.
Is that all? That's all you're going to tell him?
No,
so
my little fun fact about Paul, I think he knows what I'm going to say, but he is a world-famous clogger. For those of you that don't know what clogging is, it's sort of an Appalachian version of Irish dance, and he has actually been to China to teach some clogging. So he was in a troupe back in high school, and is pretty good.
Prove it. I've got to get more dirt on her from her family or something. Well, we wanted to kind of show today maybe a little bit of kind of a medical perspective on natural family planning. I think places like St. Gertrude do a wonderful job of teaching us the theological side of things, and so we wanted to maybe bring in the scientific side of things because we feel like both in this and in our medical practices that the two really complement each other. They're not really opposed, and so that's really what we hope to show tonight.
And I think that for both of us, when we approached, we both sort of learned about natural family planning and fertility awareness-based methods, which we'll talk a little bit about later, at different points sort of separately. And then when we met and started dating and were engaged to be married, it was just kind of nice that we both were on the same page about that already, and also kind of on the same method that we both knew a lot about. But I think that the things that we learned in medical school and then residency and practice, sort of the scientific aspects of natural family planning, I think just made our sort of spiritual, moral understanding of it so much more beautiful and richer. So that's why we want to share that with you tonight.
Absolutely. So we wanted to kind of start with what comes to mind when you think of natural family planning. And we wanted to throw in some phrases we heard during our training and kind of along the way during the years. So these are true phrases, hopefully not too offensive. So one is winging it. So that's what one of my friends told me he thought of when he heard of natural family planning. So he was like, yeah, it's kind of like you just show up into marriage and you don't really know, and you just don't know if you're going to have a baby or not at any day, right? I said, well, maybe not exactly that. So we wanted to kind of dispel the myth that it's that natural family planning is kind of winging it.
Good way to have 22 kids. Full disclosure, this is the Day family. There are 7 days. Mom and Dad Day are in the middle, and then so 7 kids, 5 spouses, and 12 grandkids are all up there.
It's right here too, isn't it?
Yeah, it is.
And something we want to point out too, obviously, you know, it allows for large families, but it also allows for small families, and you know, that's obviously something that's very importantly discerned by the couple in their relationship with God, which we'll touch on maybe a little later. Outdated, that was one I heard of a lot. A lot of people think that natural family planning is maybe like the rhythm method that your grandmother used or your great-grandmother used. And fortunately, we have a lot of kind of updated science and understanding about how things work that enable us to really have moved well beyond that.
Unscientific. Perhaps a little bit like Bill Nye and his views on life.
That's good. This is probably my favorite one. Someone told me that it was Vatican roulette. So that one I thought was at least pretty creative. So again, our hope is to kind of dispel those myths and kind of show that there's a lot more to it.
And that you have sex once per month. And another thing that we will be showing today is that if you practice NFP and are and are familiar with it and know the signs and everything, that is quite far from the truth.
So we just wanted to kind of start off by giving a baseline definition. Really our goals here are to dispel those myths that we talked about. A little bit later we're going to delve into some of the research and studies behind it, kind of showing that it has a really good scientific backbone. We're even going to compare it to other methods of family planning that are used more commonly, especially the prescription kinds, and kind of compare them head to head and talk about risks and benefits and kind of come up with why we decided to go this route with the way we practice medicine. So hopefully those are realistic goals. It's funny you mentioned basketball, because one of our unrealistic goals, I think, would be to have one of our children play basketball at any level beyond middle school. So hopefully they're good at soccer. So natural family planning, it's basically a method for couples to avoid or achieve pregnancy. And they're able to do this because they understand the underlying physiology of their bodies, and they're able to understand the difference between fertile and infertile periods of a woman's cycle. And it also has kind of, I guess, an updated name. Every 20 years we got to come up with a new name. So kind of the new thing people are using now are fertility awareness-based methods, or FABMs. I think one reason this is happening is to kind of show that it's not the rhythm method, because that's kind of the association sometimes with NFP. So we're going to use these two terms interchangeably. But NFP or FABMs, those are going to be kind of one and the same thing tonight. All right, so how does NFP work? So first we do have to kind of, take a step back and review a little bit of physiology, so hang on to your hats. All right, so we're going to kind of keep it simple. This is what sperm and egg look like under the microscope. So we're going to talk about the basic requirements for conception to occur. So to define conception, of course, that's when a sperm and an egg meet and a new individual is formed, genetically unique and distinct. So I think most of us get that. I think one of the things that is often overlooked is that it requires a third medium, cervical mucus. That enables the sperm to survive. It also gives them basically what you might want to call a swimming lane, a place to go, basically a track to run on in order to make it to the egg for fertilization to occur. So really the crux of natural family planning focuses a lot on knowing when that egg is available, or ovulation, and then learning a lot about cervical mucus. So this is usually the point at least where we lose half the guys when we say that phrase. So if anyone needs to go get a beer, please do so. Come back. We'll get through it, I promise. All right. So first we wanted to show a little video that kind of walks through a very basic look at how fertilization occurs. We're going to kind of highlight a couple of steps during it so that we can show, kind of prove some of our points later on. Unfortunately, we don't need the sound because it's in French. All right, so right now we're looking at the cervix. It's also called the biologic valve. You notice right now the sperm are not able to make it through when it's closed, and we're going to touch on that a little bit later. That's very important. So as you can see, it's not open right now.
The hearts are hormones.
All right. All right, so now we're following basically the sperm traveling through the cervix. So what they're doing right now, they're using that cervical mucus that we talked about. That's basically enabling them to have food for the journey, if you will, because without it, they really don't make it very far. So now they each go to one or other of these sides, up the uterus and into what's called the fallopian tube. That's this area right here. Notice where fertilization occurs. It's not down here. The egg is now released. Fertilization actually occurs way out here in the fallopian tube, where I guess the Michael Phelps of sperms is the first one to get there. Makes it there. So right now, as you can see, we already have a genetically unique individual, and the multiplication and growth has occurred. And this is right here is called implantation. So right here where this new genetically unique individual has implanted into the uterus and pregnancy has occurred. So a few take-homes from that we just want to kind of review while it pans out. So number one, the cervix is what's called like a biological valve. It's not always open. It doesn't always have food for the sperm to survive. There's a very particular window that happens monthly, and that's really important to understanding this. The other thing is where fertilization occurs. So it occurs out here in what's called the fallopian tube. Think of it as the slide down which the fertilized egg or the unique individual has to go in order to implant in the uterus. This is going to be important later when we talk about both natural family planning and how other contraceptives work, and comparing them head to head and figuring out what we think is the best method to use.
Can you explain the picture? I love it.
That was just one of our wedding pictures. We were just being silly.
Realizing that it was real, I think. All right. So if you guys survive that, I think you're going to do great the rest of the talk. All right. So we're going to just kind of drive that point home one more time. And really where we're going to zoom in is right here in the cervix, okay? So as we reviewed, this is not always open, and it's not always filled with mucus that allows sperm to survive and travel through the fallopian tube for fertilization to occur right here where the egg is released, okay? So now we're going to kind of zone in on the cervix itself. So what's really neat is that the two main hormones in a woman's body, estrogen and progesterone, that really dominate the menstrual cycle, what they do is they change the composition of the mucus that's there. And we're going to go over this in detail a little bit later, but what I want you to notice is think of estrogen basically as swimming lanes. And underneath the microscope, that's actually what it looks like. It creates small lanes for the sperm to travel through. Not only that, but it's very nutritive for the sperm, and it gives them a place to go to travel all the way up on that final destination that we just looked at. On the other hand, the progesterone predominant mucus is basically a stopping block. It's a barrier. It's very thick, it's not nutritive. Sperm survive maybe at most 1 to 2 days, a lot of times fewer days than that. So this is going to be kind of the one of the foundations on which natural family planning is built on, understanding this. So as a bit of an analogy, sometimes we tell people to think of it as a race, right? You always have the runners, they're ready to go, sperm are ready. The egg is the finish line, that's where they're trying to go. And the cervical mucus, of course, is the race course. And so we're not trying to oversimplify something that's sacred and beautiful, but to kind of really break it down and understand it well. What we have to remember is that if there's no finish line and no race course, there's no race. So we're going to talk about how all three of these have to be present in order for pregnancy to occur. The sperm, of course, aren't really ever a limiting factor. They're always there. The egg, we're going to talk about when it's there and how long an egg lives on its own. And we're also going to talk about how long cervical mucus is present and how that allows for fertilization to occur.
So then take a minute to stop and think about what would happen. Just imagine yourself in the race context. If there was a finish line there, but you got there on the wrong day of the race, even if you got to the finish line, you wouldn't win the race. If you didn't have the race course that was lined or well marked, telling you right where to go, you'd get lost and you would never make it to the finish line. So that's sort of why we like to think of those things.
So this is a little bit of a different look at it. So that here we're going to bring in the hormones. And so remember when we talked earlier about estrogen, or the E-type mucus, being the type of mucus that are those swimming lanes, right? Or those lanes at which the sperm can run in. So if you look, it gets highest right at the time at which ovulation occurs. So that's very important. It's coordinated. It's actually a very beautiful thing when you sit down and look and understand how these hormones kind of work in cooperation with each other to allow for this all to occur at once. And then if you look again, after ovulation occurs, estrogen falls down and then progesterone rises. That's going to make the cervical mucus that barrier, that kind of blockade that we talked about. So sperm is not able to get through that. And one more thing just to kind of take a look. So this is the inside lining of the uterus. We call it the endometrium. And so this gets built up so that it's nice and ready when ovulation occurs, so that if fertilization occurs and a new individual is created, the lining of the uterus is nice and thick and ready to receive that embryo for implantation to occur. So it's all very beautifully coordinated. If pregnancy does not occur, this lining has to be reset, and that of course is when menses begins, bleeding occurs, and then you start the cycle over again.
So, so the ways to think of the hormones in a little bit more broken down is that estrogen is what drives ovulation to happen, and it sort of is the beginning preparation, telling the maturing follicle up there to ovulate, and then telling the lining of the uterus to start getting ready in case a pregnancy is achieved. And then the progesterone, think of progestation. So it is all about like making the uterus a good, welcoming place for that new life to basically set up camp. So it's kind of like a nice little, it's building up a nice little pillow for when that little baby comes and is ready to rest.
So then we talked a little bit about the 3 essential elements, so just to kind of drive that home to the egg, the sperm, and the cervical mucus. So we're going to do a little math and talk about, okay, let's talk about a typical 30-day cycle. And don't worry, we recognize that not everyone has typical 30-day cycles, so we will get to that as well. But to just kind of break it down at the beginning, so how many days out of a typical 30-day cycle would all 3 of these elements be present in order for pregnancy to be a possibility? So this is based on a study, and we're going to get to the study. We're going to cite journals that are medical journals that are not spiritually or religiously based, because we want to show that the science actually complements the things that we believe and the things that we practice. So multiple studies really have shown that usually the egg survival is 24 hours or 1 day. Sperm survival ranges from a few hours to, they say at the very most, 5 days. And again, it's only able to do that in the presence of that E-type mucus, the one with the swimming lanes, the one that provides nutrients to the sperm. In the absence of that, the sperm is not able to survive very long. So if we're going to take the largest window possible, combining these 2 things, we've got 1 day, and under the most favorable of conditions, we've got another 5 days. So that's typically 6 days out of a 30-day cycle during which pregnancy can occur. So in order for us to have an understanding of that, we want to know, okay, how do we find out when those 6 days are in a typical given month? Especially not just looking back on the month and knowing when it is, but being able to predict it day to day. So this was a New England Journal of Medicine article. The New England Journal of Medicine is kind of one of the highest tiered journals that physicians review for medical knowledge. And so this one basically looked at these things. So they basically wanted to identify this window. How many days were there that pregnancy could occur in a typical 30-day cycle? And so they followed 221 healthy couples, a total of 192 pregnancies. These were pretty brave volunteers. I mean, they had to divulge a lot of personal information, obviously, and they were getting their urine tested like every night to measure hormone levels so that they could, correlate this with what was going on. But don't worry, that's not how NFP works. This is just for a study to kind of see how things work, okay? And basically what they found out is that it did indeed fit this 6-day window. So at most, a 6-day window. Typically though, for most people it was actually closer to a 4-day window. That was 94% of these pregnancies. So that means the day of ovulation, plus 3 days before favorable estrogen-type cervical mucus, that 4-day window on average was when 94% of pregnancies were to occur. There were a few outside, that 6% was when they stretched it to include the whole 6-day window that we talked about. So just to be on the, to be totally inclusive of all the pregnancies, we call it a 6-day window. It's typically 4 to 5 in reality. All right. So here we just want to provide a visual. You want to go over some of these and kind of the differences?
So these are, they're basically simple versions of a woman's chart. Basically, when a woman is charting for natural family planning, she is just writing down the observations that she makes each day. This one being cervical mucus. So the red at the beginning is the menstruation. The green is when there's no cervical mucus, and then the blue is when there is that fertile cervical mucus that we talk about. So these are showing different cycle lengths of a woman. So here, so the top one is a woman that has a pretty, what we would call average or normal cycle that's 29 days, with that fertile period being kind of right in the middle. We kind of think, you might have heard of like day 14 tends to be thought of as the traditional day of ovulation. The second one is a woman that has a little bit shorter cycle, 25 days, which is actually within the realm of normal. But you can see that her fertile window is much sooner, which again is absolutely not abnormal by any means. She just has an earlier fertile window. And then the last one is someone who is 35, 36 days, which is kind of on the longer end of normal, but still okay. And then her fertile window is much later. And so again, if she's making these observations, then she knows where her fertile window is. But if you sort of go back to the rhythm method or the standard days methods, where we think of like, okay, you just wouldn't have intercourse on, a certain number of days during the month, that's going to break down. If your days are right, if your days are going back to the top one where it's 11 through 16, the second one is going to miss those days on the beginning, days 6 through 10, and then the third one is going to be missing the fertile window at day 17 through 22.
We'll show you a little visual of that. So basically what we're showing here is everyone has that 6-day window that we talked about. But that 6-day window is going to occur at different times for different women. So the importance is that we can't just apply always a kind of automatic rule or formula saying this day through this day. If you're seeking to avoid pregnancy, if you don't have intercourse, you won't become pregnant. So I kind of want to show you what that looks like. So a typical method, based on some calculations, a lot of people would say days 8 through 19, if you don't have intercourse, then you're not going to become pregnant. So someone with a very typical 30-day cycle, that would work for them. And that's kind of the basic rhythm method. But as you see, if you kind of apply that to each individual, you start to miss some of those fertile days, right? So day 8 through 19 here misses day 7. And of course, applying it down here, you miss it on this end. And so I want to kind of drive this home just to show it's not just saying these particular days out of a month. There's ways to predict when these 6 days are going to be so that it can work for any variable cycle length. And it can also work even if the cycle is normal, if that 6-day window happens to shift based on the woman's particular month at that time. Okay. So then how specifically do these work?
So the mainstay is that a woman, and it does usually fall on the woman because we're the ones that are showing all these signs, because it's our cervical mucus, right? And our uterus and our hormones. So symptoms, this one is a little bit less, not as big of a focus, but it's things like, we call middle schmerz. It's a little bit of abdominal pain around ovulation, or breast tenderness. Temperature, And we'll get into a little bit more of these later, but temperature is, there's sort of like a biphasic or two-phase temperature at the different points of pre-ovulation and post-ovulation. So you can see a distinct temperature change if you take your temperature every day. And then cervical mucus, again, a woman is going to be making observations of her cervical mucus every day. And based on how that changes, she can tell when her fertile window is. There are other things like an LH surge kit. So it's kind of like a pregnancy test where you pee on a stick, and it will tell you if the LH levels, or the luteinizing hormone, which is another indicator of ovulation, if that is at its highest point.
So this is kind of and we're going to go into this a little bit later, but this is kind of a depiction of testing cervical mucus. Again, a time at which guys can usually go grab a beer, settle down. Found a cartoon version. All right. So make sure everyone was really calm after that picture.
What's his name?
Oh yeah, it's Margaret. We call her Greta for short. Yeah. So and she likes to cook. So how do these compare to modern methods of contraception? So we want to, as physicians, we want to be able to compare head to head and see, how do these work? And obviously there's kind of a different mindset behind using the different ones, but even if someone had a similar mindset, how do they kind of match up in comparison? So we're going to give a little overview of modern contraceptives. I'm trying to decide if maybe we should take a little break and have everybody come back, because there's some nice stuff in there. So let's take like a 10-minute break. If anyone has any questions, feel free to catch us or write them down, and we'd be happy to kind of go over them at the end. So we're going to take just maybe a 10-minute break before we launch into this, because it's a little bit long.
Before we get started, again, if anyone wrote down any other questions, please feel free to just bring them on up, or as we go this week.
We'll leave a little bit of time to at the end. So, all right. So now we have a little bit of some nice stuff. Pretzels, cheese. All right. So now we talked about, okay, we know how FABMs, or natural family planning, works, and we've talked a lot about the 6-day window and identifying that. But in order to compare them head to head, we really have to know how do modern contraceptives work, and how can we compare those head to head, both in how they work and the mechanisms by which they affect the body. So,
so first of all, probably the one that is the most commonly talked about, that a lot of people know more about, is the pill, which is a daily medication that a woman would take, and it typically has to be around the same time every day for the hormone levels to sort of be appropriate. I'm going to talk about just Seasonique, because this is the one that we found the package label for, but many of them are the same. The different names of the different ones, there's Yaz, Seasonique, a whole bunch of different ones. They're all different because of the different variations of estrogen and progesterone, because they're synthetic hormones. So Seasonique in particular has ethinylestradiol and levonorgestrel, which the ethinylestradiol is an estrogen, the levonorgestrel is a progestin, we call it. So the package insert talks about the mechanism of action, and again, this is the package insert that is labeled on the actual medication itself. So the oral contraceptive lowers the risk of becoming pregnant primarily by suppressing ovulation, so it's preventing that follicle from releasing the egg into the fallopian tube. Other possible mechanisms may include cervical mucus changes that inhibit sperm penetration. So remember that we talked about the fertile cervical mucus is like the lane lines that make a nice path for the sperm to go up. So the oral contraceptive changes that cervical mucus so that it becomes sticky and more of a barrier and confuses the sperm so that they're not able to get up into the cervix and around to the fallopian tube. And then the last thing is endometrial changes that reduce the likelihood of implantation. So remember, when ovulation occurs, the egg is released into the fallopian tube, the sperm come up the fallopian tube, and fertilization, so a new life, is created in that fallopian tube. The fallopian, or not the fallopian tube, the embryo, that new life, then travels down the fallopian tube and implants in the uterus. So the implantation is what is inhibited in that third mechanism, because it's changing that lining of the uterus, or the lining of the uterus, so that that embryo cannot implant in the side.
This just kind of goes over the 3 ways that, and again, this is the package insert on the medication, so something that's, been looked at by the FDA and readily available to the public on the package insert. So it would work either by stopping, that was awesome. It would work either by stopping ovulation right here. The way it does that is it gives you a low dose of estrogen, just enough to where it keeps you right here and it doesn't actually allow that rise to occur. The other mechanism it talked about was the cervical mucus that Amber touched on, we've been talking a lot about. And then the other one is kind of keeping this lining just a little too thin. So instead of building it up here, it's going to keep it thinner. And that's really important when we talk a little bit later about how another contraceptive works, because as we discussed already, fertilization has already occurred. And so if we talk about a mechanism of action, even if it's saying possible, it's on the package insert of preventing implantation, that's a genetically unique individual, which is really important. Probably the most common, one of the more common used devices now is called an intrauterine device. These are also known as LARCs, or long-acting reversible contraceptives. These are very small devices that are placed inside the uterus, and they work to prevent pregnancy. They're becoming more popular because you don't have to remember to take a medication, and you don't really have to think about it once it's in there. And when people decide that they do want to have children, they'll have it removed. But we're going to talk about some potential concerns and, again, compare them head-to-head with natural family planning and talk about why we came to the conclusion we came to. So this is a rendering of what the IUD is, or intrauterine device. There are multiple kinds. Some have copper in them. Some have a low dose of a synthetic progesterone. But they line the uterus and they sit in there. And again, we're going to look at a package insert. So this is, again, on the medication, something readily available to the public. Mirena is one of the more popular IUDs that's used. And it talks about the way that it works, and it says several mechanisms that prevent pregnancy. Again, thickening cervical mucus, which we talked about. But again, it talks about inhibition of sperm capacitation or survival. And then it just says alteration of the endometrium. So what does that mean? Altering, remember the endometrium is the lining of the uterus where implantation occurs. It doesn't say anything about ovulation, so it doesn't even talk about it prevents ovulation. So this is a little bit problematic, and this is the reason. So if the IUD is in here, if it doesn't work, if the first mechanism fails, if you will, then the second mechanism has to work, which means this lining is a little bit thinner. Fertilization has occurred. New genetically unique individual is not able to implant in the uterus, and that's medically an abortifacient. That's how that works. And again, this is on the package insert. And this is not to shame anyone. This is to just get medical information out there that we feel is not discussed as openly as it should be, just because it's important for us to kind of understand how these things work. Please.
Actually, in that same product label from Mirena, it admits that after a woman has worn the product for a while, 3 out of every 4 cycles will ovulate. 75% of the time.
Right. And so if ovulation is occurring, something else is preventing, they say preventing pregnancy, but it depends again on how you're going to define that. So fertilization has occurred, again, genetically unique individual. So I think we need to really keep that in mind. Thank you for mentioning that.
Another thing that I will add is that is particularly the Mirena, which is an intrauterine device that is emitting a low level of hormones. The other intrauterine device is the copper IUD, and that is basically just a little tiche of copper. And so what that sort of touts is, oh, it doesn't have any hormones, which is great, but it's creating, and I believe that this is even the language that they use, is a hostile uterine environment. So it's basically causing a local inflammatory reaction within the uterus that prevents implantation. So it's actually causing inflammation within the uterus.
When I think hostile environment, I think like going to an away game in the UK. My association with that.
Or for me, that place up north.
Right. So we wanted to touch too on some health concerns regarding hormonal placement.
So for copper is really dangerous when, I mean, normally you don't want those levels to be up high, even in a regular body, right? Like, isn't it, I mean, it's also introducing copper into your body.
So with the copper, because it's all within that that little device, it's not actually going anywhere else in the body. It's not getting into the bloodstream. The copper is all staying within the uterus, but that is causing that local inflammatory reaction. So right there, that inflammation in the uterus right there.
Good question.
Yeah.
So again, we're going to talk about a couple of articles, and again, we're going to cite very kind of highly esteemed medical journal articles. Again, this one's going to be the New England Journal of Medicine, the one we mentioned before, that a lot of physicians use for just day-to-day information on all basically the clinical aspects of treatment. Sorry if that's not showing up real well. This one has been really controversial since it came out. So this is pretty new. It's December 2017. It talked about, it was a study in Europe. They were able to kind of keep prolonged medical records of women using hormonal contraception. And the big deal with this study was that it's a newer one. So in the old days, hormonal contraceptives had much higher doses. And now we have lower doses, now we have IUDs, different things, so they want to know, okay, is this risk still real? Is this still a thing? Or are people making it up? So this is important, we need to know about this. And basically the answer is that it is still a significant risk factor for breast cancer. They did a study and it showed that if they had used it, had ever used it, and especially if they had used it for longer than 1 year, and they were able to correlate the risk with the longer they had used it, the higher the risk of breast cancer. And so 1 versus 5 versus 10 years, there was a statistically different risk. They kind of broke it down in, and this number sounds kind of funny, but I want to talk about it a little bit. They say that, so 7,690 women all use contraceptives for a year, one of them will get breast cancer from that. Now, of course, that sounds like a big number, and it is, but again, that's using it for 1 year, and the average person is not using it for 1 year. And the percentage of people that's on it, that's still a very large number when you're talking about what a huge percentage of people are on these medications. And so, again, we recognize as physicians that when we prescribe a medicine, any medicine, if it's for your cholesterol or your blood pressure, things have risks of side effects. But we feel like it's important to discuss that and discuss, does the risk outweigh the benefit or vice versa? And so we're starting to kind of compile a lot of evidence that we don't feel like is adding up really well to use against the fertility awareness-based methods, which of course we're going to talk about later, of course don't have these.
So this is a slide showing what is more patient-reported. So not necessarily the big ones like breast cancer that we think about, but the adverse effects that patients are telling physicians, hey, this is what I'm experiencing when I'm using hormonal contraception. So it goes everywhere from acne to nausea to weight gain, irregular periods, and that's, you can see it's with all of them. So again, it's not. You can see that these side effects are similar to side effects of what you might see with an antibiotic, with some nausea, or headaches with lots of medications, all of those things. But you can see that there would be some very significant ones. If you're newly married, decreased libido, or depressed mood, those could really have some negative impacts on relationships, and then just other sort of unwanted side effects as well.
And we want to point out again, so this is from the American Family Physician. This is again, a peer-reviewed journal article, non-religious based. This is very objective data. We just kind of want to keep kind of harping on that, that the information's out there, it's just not talked about a lot. So we just kind of walk you guys through, okay, so we were in separate medical schools, didn't know each other at the time early on, but we kind of reached the decision point of, okay, how are we going to do this? You know, are we going to use these medicines? Are we going to try to apply this? How are we going to do this? And so we kind of had to think a lot about, is it good for the patient? Is it the right thing to do? Is it the moral thing to do? Is it scientifically good? And so we asked a lot of these questions, and we want to walk you guys through a little bit of that and how we came to our conclusions. So 3 things that we felt like were really important is we have to be medically consistent when we're using medicine. So we talked about risk versus benefit. We talk about that with all of our patients, with every medicine we prescribe. Is it medically effective? If I have an alternative that maybe is a little bit against the grain, I want to be able to honestly tell the patient that it's as good or better than what's being offered for them. And again, like we talked about, the benefit outweighing the risk. So these are all really important as far as coming to the conclusion of how you're going to approach this.
And I will give a little bit of a personal testimony. So Paul came to an understanding of fertility awareness-based methods more through medical school and learning about them, and then the church's teaching. I actually had a little bit more personal experience. I was blessed when I was in high school to have a physician that when I was having some irregular cycles, rather than telling me to take a birth control pill, said, hey, why don't you do this thing and start charting so that you're observing your body's natural signs and symptoms so that we know what your cycles are doing, and we can use that to, we can look at what's going on and excuse me, use more natural means to sort of help you get back to a regular pattern. So through that, I started learning the method long before Paul was ever in the picture, but just myself. And I was able to come to an incredible understanding of my body and the way that it was supposed to work. And I was able to use that to sort of get back on track. So I was able to personally experience how good it was for a patient, for me, the patient, and that I wanted to share that with others.
So we want to walk through a couple scenarios with you. So we're going to talk about a few different hormones real quickly. So growth hormone, we've all heard of this, mostly in the news. So growth hormone, you can be deficient in growth hormone, and it causes what's listed there, so it makes sense. It helps you grow. So without growth hormone, you have short stature. I did not have growth hormone deficiency. It's just kind of
Neither did I.
And so, of course, this is recognized as disease, right? So it's the absence of normal physiology. And so we treat this with growth hormone. It makes sense. It's very medically consistent. We've also seen when maybe growth hormone is used when there is no disease present, right? So if you have normal growth hormone and you're using it in an illegitimate way to gain an advantage over others in a super physiologic way or a way that is not designed for your body to work, you're going to have side effects from that are listed here. So obviously, we would write growth hormone for someone with a deficiency. We're not going to write growth hormone for a baseball player. Just kind of medically consistent. Another thought is, so the thyroid hormone, this is a very common disease that we see very frequently. The most common cause is called Hashimoto's. It's basically an autoimmune disorder of the thyroid. Typically, further on in the progression of that, people require thyroid hormone because their body does not make enough. And so we have blood tests that will objectively tell us, is the thyroid level low? Yes, it is. All right, well, medically, that's a disease. It's the absence of normal physiology. We're going to treat that with thyroid hormone until those levels are normal. This is not as common, but it is sometimes abused for things like weight loss because it speeds up your metabolism. It can have side effects with heart rhythm problems and thinning your bones. And so If someone had normal thyroid hormone, I would obviously not prescribe this for them to help them lose weight, because that would be an abuse of the medicine. It wouldn't be using the hormone properly. So if we think about these two hormones, right, growth hormone, thyroid hormone, I promise we're getting to a point here. We want to be consistent in the way we practice medicine. And so we've been talking about a lot of hormones. We've been talking about estrogen and progesterone.
So then let's take a look at estrogen and progesterone. Estradiol is sort of the, it's one of the forms of estrogen, and that's sort of a lot of times what we talk about medically, often because that's the one that we actually measure in the blood. So when everything is working, normal physiology, the estrogen and progesterone are at the right levels. That's what brings about monthly cycles, ovulation, and fertility. So when when a woman is ovulating and then having a period every month, that means that that means that those hormones are all in balance, that they're working appropriately. So if we apply the same principles of the thyroid hormone and the growth hormone to reproductive hormones, we ask ourselves the questions: if there's nothing wrong with the way that the body is working when a woman is having monthly cycles, is ovulating, and is fertile during that 6-day window every month, is it medically appropriate to give her a contraceptive, either device or a pill or what have you, that is going to give her abnormal amounts of hormones when her body's already working just the way it's supposed to?
Absolutely. So this made me think really hard about, are we calling fertility a disease at this point? And this is stuff that's been taught to us by docs that we've been blessed to know and that we just like to pass on. So in order to be consistent, we don't feel like you should be treating this with hormones when you're treating normal physiology. So now we're going to kind of come around and bring them together, right? We talked about natural family planning, or FABMs. We've talked about hormonal contraceptives and how they work. Now, do they work? And not just do they work on their own studies, but let's compare them to methods that are used commonly. So again, I'm going to show you an article from the American Family Physician. Again, the peer-reviewed journal article that has lots of information for our daily clinical practices. And they have this really nice table that compares different methods that are used. And so I want to kind of walk through this with you guys. So on the left hand, it talks about typical use. So this allows for human error. So if it's a medication, like the contraceptive pill, it allows for, some days are missed, or someone forgets to take their medication, something like that. And in perfect use, it talks about this. Now these numbers are the number, the percentage-wise of unintended pregnancy in the first year of use. So if we kind of walk through these, we want to start at the top. They basically, if you want to use the term, become more effective as you go down the line. And so the ones that we talked about with you guys earlier, and some of the more commonly used ones, are the oral contraceptive pill and the intrauterine device. Now, of course, this intrauterine device, the typical and perfect use, are going to be about the same because there's not much room for human error, as we talked about, because it's a device that's placed. But if we're going to look and compare head-to-head, let's go down to some of the most commonly used natural family planning methods, specifically the symptothermal method and the Creighton model. Those are the two we'll probably talk a little bit more about. So typical use, we're talking 2 to 8%, 2 to 5%, which is better than oral contraceptive pill. Again, obviously the IUD is not allowed for any human error, but then when we look at perfect use, or when it's used, it's understood well, and people are consistent with it, less than 1% unintended pregnancy. And this is, again, in a peer-reviewed journal article. So this article is great. I invite you to, you can Google it and get access to it. It was in 2012, the American Family Physician. And at the end, they kind of cite a bunch of the articles that they used to compile this information. So in a head-to-head comparison, they match up really well. In fact, in some of them, they're a little better.
The other thing that I will point out is that when you look at the natural family planning methods and their typical use, that term for natural family planning, typical use, is a little bit cloudy because there's typical use of, did I forget to chart one day, or did I make an erroneous observation, or was it purely, I knew that I was fertile on a given day, but we chose to have intercourse anyway, and we were well aware of the possibility of pregnancy, and were open and joyful about that. And so, was that really a failure, or was that a win?
Right.
Are there statistics on efficacy using it long term? Because I know a lot of people discontinue artificial methods after a year or so because they don't like them. They're having these side effects. And on the flip side too, I know a number of couples who using NFP have had a surprise blessing once, but then they're like, oh, now I understand at a deeper level how this works. So I'm just curious, this is like with, is this averaged out over 10 years of use, or is it like studying it for 1 year? Do you know?
Sure.
These
So
studies?
this combines a bunch of studies, and it basically looks at 1 year, first year use.
Yeah, because I would be curious to see, I bet those numbers would get better
Even lower.
over time.
Right,
Yeah.
more confidence and experience with the method.
Mhm.
Absolutely. That's a great point.
Mhm.
We'll have to put that in this article in 2018. All right. So we're going to give just a little overview.
Yeah, so I'm going to spend most time on the symptothermal method and the Creighton model. So the symptothermal method is the method that's usually taught by the couple-to-couple league. So that one is going to use basically a few different things. We talked about the cervical mucus, we talked about the temperature, and then we talked about some of the symptoms. The symptothermal method is kind of the combination of all of those. So the temperature piece of that is that a woman checks her temperature at the same time every day with a special thermometer that is a lot more accurate than your regular thermometer from Kroger. It goes to, I believe, the 100th of a degree, so 2 decimal places. And so, because sometimes the variation in temperature is that tiny. So you can see that day 17, 18 is about where ovulation occurs here, and you can see that the basal body temperature, so the basic sort of when basal body temperature means when, sort of what the body's temperature is when nothing else is happening. So you're having this sort of marathon, you're not super cold, you kind of just woke up, you're supposed to take your temperature right when you get out of bed or before you get out of bed in the morning. And then so after ovulation, that temperature jumps. So by charting and writing down your temperature every day, you can note the change and very accurately predict about when ovulation occurred. This is great for people that have a regular schedule. It didn't quite work for me so well when I was in residency because I was waking up at all different hours in the morning, sleeping in different places because sometimes I was on call. So this is good for someone that has a pretty consistent schedule and maybe isn't working night shifts or that sort of thing. So the symptothermal method combines the temperature as well as those symptoms kind of that we talked about earlier. That's a smaller piece of it. And then observation of cervical mucus. So basically what this means is that a woman every time before and after she uses the restroom, because that's when she's sort of bearing down and that cervical mucus can come out, she is just observing with toilet tissue what that mucus looks like and then just making some quick observations. It sounds gross kind of when you first learn about it, but then it kind of becomes second nature and you almost don't think about it. So this slide is kind of a progression of what the cervical mucus looks like throughout the cycle. So this is sort of, if you think of that fertile window, this is at the very beginning of it. There's sort of a very little, very small amount of very cloudy white cervical mucus. Then a few days later, it gets a little bit stretchier, if you will, and you can see that it's a little bit clearer. The third picture is sort of that like peak what we call peak, the most fertile mucus that happens within about 24 to 48 hours of when ovulation occurs. We like to think of it as egg white. And then the last picture is sort of that progesterone mucus. It's thicker, it's kind of gluier, gummier, is what the methods, the verbiage that they use. But think of it as that like real sticky mucus that isn't going to let the sperm get anywhere, versus the egg white mucus that's like that perfect lane line that's going to let the sperm go right where it's supposed to go. So then on this slide you can see where so the top is the chart. So the red and that kind of like brown color is first is blood for the menstrual cycle, and then the brown color is when there's no mucus. The white babies is when the mucus is that fertile mucus. So you can see that the LH, which is that spike when the peak day or the ovulation day happens, and then the estrogen is rising here. So you can see that that's like the white babies are the estrogen type mucus. And then when it goes back to the brown, that's when the progesterone is rising, and that's that progesterone mucus. So then this right here is an example of a Creighton chart. So remember, the symptothermal method uses the temperature, the symptoms, and the cervical mucus. And then there's the Creighton method, and Creighton is all observations of cervical mucus. The difference is that the Creighton method has, I believe, a little bit more specific grades and observations, details about the cervical mucus that you're writing down every day. So you can see the menstruation, and then the green, these are stickers that a woman puts on her chart. The green is when there's no mucus, and then the white is when there's fertile cervical mucus. This woman, you can see it says 10K or 10C. That is just those details, the grading of the cervical mucus. And then you can see a P up there with a 1, 2, 3 after it. The P is the peak day when we think ovulation occurs, which truly ovulation usually occurs within about 24 to 48 hours of that peak day. So we always consider the peak day to be the last day of that fertile cervical mucus. And then the Creighton method also has you those green babies, the 1, 2, 3. It's called a count of 3 after that peak day, just to provide a little bit of extra cushion. So you can see that that the white babies before, in that fertile window, are allowing for the survival of the sperm. So if intercourse occurs on day 14, that sperm could survive for 5 days in sort of the perfect conditions. So if ovulation does occur on day 19, then fertilization could occur. So if a couple is trying to achieve pregnancy, then they are going to be able to use that fertile mucus and use their observation of peak day as those couple days when the highest likelihood of achieving a pregnancy is occurring if they have intercourse on those days. And if the couple is trying to avoid pregnancy or feels called to avoid pregnancy, then they would abstain during that fertile window. And because we said that fertilization or ovulation occurs sort of within that window and fertilization occurs within that window, if they abstain during that time, they won't achieve a pregnancy.
And for those of you who may not know a lot about the details of both these methods or other methods, we have a handout with the ability to reach out to a teacher or instructor. So this is not meant to be comprehensive and for someone to be able to go home and use this method. It's a very brief overview. There are people that are trained very specifically and to teach you how to use it and become confident with it. And there's no best method. The method that is best is the one that works well for you. There's lots of methods out there, so We don't really ascribe to one in particular. So we just kind of want to give an overview of some of the popular ones. But just know that this isn't meant to be comprehensive as far as how to use it. There's specific teachers that would instruct you on that.
Mm-hmm. There are also a couple of other, these two are the most common, but there are a couple of other methods and signs that people use in various of the other forms of natural family planning. One is looking at the position of the cervix, and there's ways that a woman can check that. There's also those LH surge kits or ovulation kits that, again, it's like a pregnancy test where a woman urinates on a stick, and then there's an indicator of whether that LH is at a high level or not. So again, those are less common, but still used in very good methods when they're combined with sort of all of the cervical mucus and the temperature and all of those things. Another thing that I will say, if you want to go back to that chart, there's a lot going on there, and it's really confusing. It's not an overnight thing that it takes till you can't just learn it overnight. It is a little bit overwhelming at first, and like any thing that has a lot of reward, it does take a lot of time and effort to learn it. But once you do learn it and become comfortable with the method, it really becomes second nature. A lot of times, couples, when they first get married, they sort of start off feeling called in, their goals are sort of to avoid pregnancy, at least for a time, and then when you feel the Lord is calling you, then your sights are more focused on achieving pregnancy. A lot of times, couples are more concerned with how is this going to help me avoid pregnancy. And I just always like to say, a good priest friend of ours commented once that that's oftentimes the focus is how am I going to be able to avoid pregnancy? And then once you get married and are sort of in the throes of your life, you realize that you're more concerned with am I going to be able to achieve pregnancy than how am I going to be able to avoid pregnancy. Which is why these methods are so beautiful, because just like I said, you have a higher chance of getting pregnant if you have intercourse on peak day than if you're just playing Vatican roulette.
Bring that back. That's good. Appreciate that. Oh man. So there's also kind of branches of natural family planning and specific training that you can get. And so there's a science called NAPRO technology, or natural procreative technology, and that uses natural family planning to basically address underlying women's health issues. So we find this is really important too, because like we talked about, if we're not able to offer patients what may be considered the standard of care with things that are prescribed currently, we want to be able to address underlying health issues and still be able to care for them as a whole person. So I'm just going to do a very brief overview of these and cite just some specific examples. It kind of goes, this is almost its own talk in and of itself, but I'm going to just highlight a few things and be happy to take questions that people have. So I'm just going to go through 4 specific cycles that all kind of show something different and kind of highlight maybe if you were seeing a physician trained in this area, what he would be looking at, what he or she would be looking at, and what you guys might be talking about. So on the top chart we see, you remember that lovely 5-6 day window before ovulation? So obviously this person does not really have that. And so what we're seeing really is a lack of cervical mucus. Remember we talked about the sperm don't have a lane to travel down, they're runners without a course, right? And so they don't really have anywhere to go. So sperm can't survive, and this can be a cause of infertility. And so what we would do is we do a hormone profile, look at estrogen and progesterone. Because remember we talked about those are the things that change what the cervical mucus looks like and does. And so we would do some lab tests to take a look at that. We would also look at medications that enhance cervical mucus. There's a handful of different ones that we use for different people. And what that does is it helps restore and replace that normal physiology that isn't there. Let's move down to the second one. So this one is one that could potentially end up in miscarriage. The reason being, you can see that ovulation occurred and there was lots of mucus before. So really we had it looks like we probably had all 3 things that we needed that we talked about, right? We had our runners, the finish line in the race course. We had the sperm, the egg, and the cervical mucus. The issue is, right here, this cycle should be going out a little bit longer. And remember when we talked about implantation, or when that new genetically unique individual is implanting in the uterus, it needs that nice built-up lining, that healthy lining. And so sometimes if there is not that healthy lining, this new unique individual, the embryo, is not able to implant in the uterus. And so that can be a cause of miscarriage. So a patient with this, we would be getting, again, hormone levels, and more than likely they would need more progesterone to help with that. Please.
So understanding that the cervical mucus is mainly a function of or totally a function of the hormones. Have you guys ever heard of, or do people ever talk about, are there any other factors that more that people can control? Do people ever talk about their diet or their hydration as a function of cervical mucus, or is it just your hormones?
Good question. There are some other factors. So one thing can be locally. So sometimes there are cysts or clogged pores around and in the cervix that can be formed, and sometimes that requires a very minor in-our-office procedure to clear those up. There haven't been, I would be interested to see, because there's probably a correlation, a lot of studies on particular types of food and things like that. Hydration status is definitely important. There was it's kind of like the old wives' tale, you could take this over-the-counter cough medicine. Robitussin, right?
Yeah.
And get pregnant, and the reason was because it had the ingredient for mucinex in it, which causes more production of cervical mucus. So there was actually some truth to that. And so for some it's hormonal, for some it's the local actual production of the mucus. There are some conditions people can have that cause chronic inflammation and things like that, and they're not going to make as good of mucus. And so if we're not able to address that underlying cause, we can kind of amp up the gland's ability to do it, if that makes sense. So, good question. Another one is low progesterone. And so what we see here is so after ovulation occurs, so again, we're having kind of the three things we talked about. Not a lot of surgery, but enough for sperm survival. Ovulation occurs. But you see at the end here, there's a type of bleeding that's going on much sooner than it should. What happens here is that the buildup of that lining isn't really strong, and so it's not able to hold on to what it needs to, and bleeding occurs very early in the cycle. We also see this a lot. This can cause a lot of actual physical symptoms too. PMS symptoms, bloating, nausea, mood change, all these things can very strongly be correlated sometimes to hormonal levels. And so, again, we'd be getting a hormonal workup. We get specific time-targeting labs here in this phase. And I want to emphasize too, so if someone were getting labs to test the menstrual cycle, you have to know where in the menstrual cycle you are, right? Otherwise, if they're get it, 15 days after your cycle, that's actually winging it, right? So that's kind of guessing where you are. When you're using one of these methods, any of the methods that allow you to identify when you're ovulating, we know what the hormone levels should be at that time. So if we're just getting in on random days, there's not a lot that we can work with if we don't have this chart to kind of help us correlate where those hormone levels should be. Because remember, when we were looking before, the estrogen varies quite a bit, as does the progesterone. And so knowing the exact day that we're at is incredibly helpful to treating underlying conditions. And the last one on the end here is a pattern of abnormal bleeding. This can be a whole lot of things, so I won't go into a lot of it. It can be actually like a rare underlying kind of chronic endometritis or inflammation infection. We do see a lot of abnormal bleeding in polycystic ovarian syndrome, or PCOS. That's a condition, I guess to simplify, in which the hormone levels are imbalanced, and there's a higher level of male hormones than there should be in a female. And what that causes is the ovaries form cysts, and that kind of makes the problem worse because those produce more hormones. And so ovulation really has a hard time occurring at all. A lot of times with PCOS, we see cycles that are well over 30 days because it takes the body a long time to finally ovulate so that things can reset. And so someone with PCOS, we would use a medication that's that a lot of other physicians, non-NAPRO trained, use called metformin. It's a medicine that we use actually for diabetes. It's an insulin sensitizing agent, so what that does, it allows the body to respond better to those hormones. A lot of times with just that alone, we're able to get back to a better cycle of ovulation. And then if they're not able to ovulate, we can use some medicines that help stimulate ovulation. And then of course we can do our hormone workup as well. So these are a few kind of, I guess, conditions or things that we might see that we could treat, but we're helped by knowing where someone is in a cycle. And so without that critical information, we're doing a little more guesswork than we would be otherwise. And so honestly, as physicians, we're incredibly grateful that this exists because it allows us to help people in a much more real way than we would be able to otherwise. So, we did want to end, since we were citing studies, and this one, admittedly, is a Catholic journal, so full disclosure. But they did talk about divorce rates in couples that use natural family planning versus couples that do not. And again, there's going to be a lot of compounding factors, right? If someone's using natural family planning, they're probably not of a high divorce mindset to begin with, obviously. But that being said, you know, in medicine, the big push now is for evidence-based medicine. So you have to have evidence for the medicine that you're using. And so to answer that last question of, is it good for my patients? So not only is it physically better for them, not only is this method not going to have side effects, yes, it takes a little bit of work at the end, but the results really do speak for themselves. And so it's a joyful part of what we do. It's nice to have the personal experience, but it's really joyful to have the medical experience as well. I don't have anything else. So if you guys have any questions, we'd be happy to answer them.
I'm just going to say that with the contraception, the World Health Organization has declared that a level 1 carcinogen is the same as cigarette smoking. People know that. And I think the divorce rate is smaller because it takes greater communication to use natural methods.
Absolutely, yeah. But yeah, more on the personal side, we have found that the fruits of it within our marriage, specifically enhancing communication, helping us to respect each other. I feel very respected because Paul is not, we're not treating my fertility as a disease, but something beautiful that we should embrace and use the natural cycle that God has given me to discern what, and to use prayer to discern what the Lord is calling us to. So those are the fruits for us personally.
Absolutely.
I have a really dumb question.
No.
So, if someone was coming to see you, like in what context? I know he gave the bio about like where you work, but I'm, you know, like not an OB. Like what context does someone seek you out? Is it just in this vein, or is this part of? I don't know.
No, that's a good
Yeah.
question. So I do primary care, so I
Okay.
see all ages, a little bit of everything. But with the extra training in this, a lot of times sometimes patients will be sent to me if they're charting and their instructor notices that there's an abnormality that they feel like they would benefit from treatment. Sometimes it's patients who have struggled with infertility, and it's from all walks of life. I mean, this has a lot of, this is gaining a lot of traction. I mean, it's green, right? So we joke that we like to see the hipsters in our clinic as well. So I bring in my artisan coffee and try to wear a plaid shirt. Make them feel right at home. So, but in all honesty, so some people have tried IVF, or maybe they couldn't afford it and they're just looking for an answer. Sometimes they're seeking to avoid pregnancy and their chart is all over the place and they just need some confidence. So all of those factors. But admittedly, usually if they're not charting, our hands are a little bit tied. There's still some things we can do, but the chart gives us so much information, like we talked about. So a lot of times if they're not charting yet, we'll do what we can and triage some things and say, let's pick one of these methods and get really familiar with this so that we can really pinpoint what's going on.
Another plug for NAPRO technology is that the success rates for infertile couples are actually higher than that of IVF, but no one will ever tell.
say anything about serious reasons for doing it. And that's kind of left out of the picture in terms of an idea of what are you getting married for.
Right.
And it's, to me, very close to saying, well, we're backing birth control. You know, we just say, we're going to do this, and we will be in charge of what occurs in our lives, as opposed to saying, hey, why don't we want to multiply, that's what God intends. And so I just think it's a really big hole in terms of the natural family planning. Can't see where that's being left out. It's just.
I'm glad you mentioned that. And I think one reason we didn't touch on that a lot was because we wanted to try to approach it just from kind of a science perspective. But that is incredibly important. So just like any other gift, it can be abused or misused with the wrong mentality, 110%. And so Pope Paul VI in Humanae Vitae does talk about grave or serious reasons. And that is something that each couple, together in their relationship and in their prayer life needs to discern. And so just like any other gift, natural family planning could be misused with the wrong mentality. So I'm glad you mentioned that.
Okay. Nope, sorry.
I was just going to add to that. I appreciate your bringing your expertise as practitioners. My husband and I do a very similar presentation at a pre-Cana retreat for married couples twice a year offered at our parish, Immaculate Heart of Mary, out on Beachmont. And we do make reference to that very topic also. I understand that coming here to St. Gertrude, that wasn't necessarily the focus of your talk, but not only Pope Paul VI, but especially John Paul II elaborated quite a bit on that concept of responsible parenthood, and that it also includes the responsibility of us as married couples to thoroughly and honestly discern. So, but I appreciate your raising that point.
Well, I was just going to say that we had a really good experience with the NAPRO technology because before this little guy, we had a miscarriage, and because of charting, I suspected it was low progesterone, but I went to a regular OB, and they were like, oh no, we don't prescribe progesterone, that's like almost witchcraft, or whatever, that's like old wives' tale progesterone. Then I went to a NAPRO technology doctor, and they were like, oh my goodness, your progesterone is so low, you need to because I was pregnant the next month, basically, and they were like, you need to get taking progesterone every day, and you need to get shots of it. And then he's like a miracle. I mean, I think it's totally NAPRO technology is such a blessing. And who knows, if we went to a regular OB, they would have been like, oh, you have to have 3 miscarriages in order to even be seen.
Thanks for sharing that.
I have a question. I go to my OBGYN, he doesn't do NFP, but I'm 54 and still having menses and all that, and he just doesn't really offer me anything. I mean, is it normal? I mean, do you think that people that are on the pill and getting sterilized, that they go into early menopause, that people that don't do that are kind of abnormal now, and we just kind of wait it out because we don't know what's normal, not normal with our doctors because they don't see people go that late anymore. Is that true, you think?
That's a good question. So I don't know of any studies that kind of compare the two as far as age of onset of menopause. The average age that's usually cited is 51, and so of course with any average you're going to have some outliers on both ends. So I can't really speak to the specifics, but as far as a comparison, there's not one to my knowledge. I can't think of a mechanism that would directly affect it happening earlier, but I would say that it's possible. So, sorry, I can't answer that better.
No.
There's also a couple of questions here that I want to address. First of all, there's one about the use of injectable birth control. So I just want to speak a little bit about the side effects of the injectable birth control. I think specifically the one that we're used to is Depo-Provera, which is a shot that a woman receives every 3 months, and it's a high dose of a progesterone hormone that is a contraceptive method. The main side effects that we think about with Depo-Provera are weight gain, and also the thinning of bones. So the minerals in the bones kind of they're just decreased a lot. So in regards to whether or not that's dangerous, I would say that all of the birth control methods have side effects, so there isn't necessarily one that is or more that are safer than the other ones. They all sort of have their side effects and their risks and benefits depending on how you look at it.
Yeah, someone asked, does the monthly cycle become affected by the pill over time negatively? I would say maybe the short answer is we kind of went over the systemic or whole body side effects. As far as the cycle being affected negatively, I would say that more often than not we just see that it's covering up an underlying issue, so that when someone comes off of that medication, that issue is either still there or maybe has progressed a little bit. So it'd be kind of hard to know the chicken or the egg if that actually caused it. But a lot of times it started for a problem, it's removed a couple of years later, the problem is either still there or has maybe progressed. And by problem I mean, specifically polycystic ovaries, endometriosis, things like that we see commonly.
Dr. Day?
Yes.
I just have a quick question. You had talked about like thyroid hormone deficiencies, etc., and that there's medicine to fix those. It seems like there's not many. I guess is it just metformin that's the only one as far as fertility that will fix a cycle that is not normal because there's a deficiency in a certain hormone.
Yeah. So metformin is sort of one of the medications that we use, but we also use what we call bioidentical versions of the hormones. So we talked about in the contraceptives that those are synthetic forms of those hormones. So we, NAPRO technology uses bioidentical, so much more like the body's actual hormone that it's making. And we give those hormones at specific times of the cycle based on a woman's chart to sort of replenish, if a woman's low in progesterone, then giving progesterone at those times during the month when she's supposed to have progesterone to sort of reestablish normal physiology.
Do those act like a birth control still, or is it or would it return you to normal?
Yeah, the idea is to get you to normal physiology. Absolutely. So one of the issues with PCOS is if you don't ovulate regularly, the endometrium can build up, and that can actually be a risk factor for endometrial cancer. And so getting someone back to normal physiology is going to lower that risk. The PCOS is also pretty complicated. I'd say every 5 to 10 years there's kind of a new thought on the underlying issue. One of the more popular ones now is that it could be a type of underlying autoimmune disorder. So it's a pretty complicated thing, and so we're getting better at treating some of the hormone problems that we see with it. But as far as really nailing the basal level biomolecular issue, it's been a little bit evasive. So.
Thank you.
With the effect on fertility or your cycles, I know Mercedes Wilson, I've heard her present a couple times, and she talks about that birth control can age your cervical cribs faster. I don't know if that, I'm just curious if that's something, I don't remember what study she was basing it on. I just didn't know if that was something that you had heard. So you might end up being less fertile later.
Yeah, that wouldn't surprise me. I want to read that actually. Yeah, because it wouldn't surprise me, but I just haven't come across it. So yeah, yeah, it makes sense. Sure.
The people that come to see you that I guess maybe are looking for fertility help and have been on, say, contraceptive hormones or whatever, how long do you see that being a problem before, as far as weaning them or getting off of the effects or of those?
It varies quite a bit as far as why they were started on it in the first place. And so I have someone that was pregnant pretty soon after stopping it within a few months. And some people, they struggle for much, much longer than that. And a lot of that, I think, depends on how long they've been on it, what type they're using, and if they were put on it at the beginning for abnormal cycles, then that was probably because there's an underlying issue that would be affecting their fertility. So once we remove the pill, then that still manifests itself and we still have to treat it. So I guess it's a convoluted answer, but it kind of depends on why they were on it and for how long. And so it varies quite a bit person to person.
The other thing is that, because remember we talked about that the contraceptives change the cervical mucus, so they interfere with, if a woman is making observations, those observations would not be accurate with the contraception. So if the physician who's practicing nanotechnology is going to look at a chart and be able to help her based on a chart, it would have to be some time for the cervical mucus to sort of get back to the woman's sort of normal patterns.
Thank you guys so much.
Thank you.